TopMedTalk. It's my privilege to welcome you to the Morpheus Plenary Lecture. For those who are not familiar with the Morpheus Consortium, it is a collaboration between three universities, the University of Southampton, University College London, and Duke University, where I come from, attempting to advance the science of perioperative medicine focused on innovation as well as education for the moment. So it is my privilege to introduce our speaker for this Morpheus lecture, Professor Denny Levett. Denny is a professor in perioperative medicine and critical care at the University of Southampton and a consultant in perioperative medicine at Southampton University Hospital NHS Foundation Trust. She leads the perioperative medicine service at UHS, which includes a preoperative cardiopulmonary exercise testing service, a preoperative anemia service, a surgery school, a shared decision-making clinic, and a prehabilitation program. Her clinical and research interests explore the role of exercise in preoperative risk stratification and preoperative optimization to improve surgical outcomes. I believe some of those questions were asked in the last session. How do we do this? So she'll fill us in on that. She's currently the president of the Perioperative Exercise Testing and Training Society, PUTS, and has established and chairs the National Perioperative Cardiopulmonary Exercise Testing course. She's part of the Fit for Surgery research group in Southampton, investigating exercise, psychological, and nutritional prehabilitation, and is the clinical lead for the multi-center WestFit trial. She's also the clinical CI for the INSPIRE trial, evaluating inspiratory muscle training before surgery as a means of reducing postoperative complications. Dr. Levett was the research leader, the expedition medical officer, and a member of the climbing team on the Caldwell Extreme Everest Research Expedition, a high-altitude field study of hypoxia adaptation. And some of our most significant publications, including one in the New England Journal, were focused on this particular project. So it is my pleasure to welcome Dr. Levett to the stage, and appropriately titled today, the lecture is Exercise is a Perioperative Medicine.
Thank you. Thanks, Joseph. What I'd like to do in the next little bit of time is to tell you why I'm passionate about exercise, really. So my interest, as Joseph suggested, first started when my PhD was exercise testing on the slopes of Mount Everest and looking at how we adapt functional capacity in response to hypoxia. But today I really want to impress upon you why I think physical fitness and measuring physical fitness is important for life generally, and it's something we should think about a little bit more for our patients because it's a modifiable risk factor, and if we modify it, we might not only improve their outcome from their upcoming surgery, but their longer term health outcomes as well. I want to talk a little bit, we might be a bit bored of pandemics, but I personally think this is a worse pandemic than the one we've just had, and its impact, if we don't do something about it, is going to be even more far-reaching than COVID has been. This is about the global inactivity pandemic. So every time we've done activity surveying globally in the Western world, in the last 50 years, every single time we measure it, physical inactivity levels get higher. In 2012, the World Health Organization announced a campaign to reduce physical inactivity by 10% as one of public health's best buys, because its lack of physical activity, physical sedentariness, is estimated to be a direct cause of about 5 million deaths globally. That was back in 2012. So since we had this campaign, what happened when we measured it again in 2018? Well, global levels of inactivity increased from 23% to 28%. And if you happen to live in the developed world, that actually covers the fact that in the developed nations, it's 43%. And if you're a woman, this is rather alarming because just now that was men. And as you can see, the women are darker, which means more inactive. And on average, we're about 8% less active than our male counterparts, which is pretty shocking. Now, that's all based on survey data, and you might say we're not very accurate about surveying, although in my experience, patients tend to underestimate what they actually do. But when this has been measured objectively, this is one of many studies published at the end of last year using accelerometry, it's really shocking. So less than 5% of awake time doing moderate activity, high intensity activity, less than 0.1% of the time. So this was middle-aged adults, 30,000 of them in Scandinavia, who on the whole are quite an active population. Even more worryingly, when you look at the projections currently, unless we do something, sedentariness is only going to increase because we've reduced the amount of activity that we have occupationally, and unfortunately the advent of screens and time on the internet and less time outdoors means that this will be increasing by another 10 to 15% by 2030 unless we do something. And does it really matter? Well, on the left there, this was a really great bit of research published in The Lancet, which was combined from the Centre for Economics, as well as these physical inactivity surveys from across Europe. And you can see, first of all, England is proudly leading the way with the highest levels of inactivity in the whole of Europe. And then what they did in this paper is to look at this concept of the population attributable fraction. So that is for each of these diseases. So of the coronary artery disease in the UK and in the rest of Europe, how much of it is directly caused by a lack of physical fitness? So quite shocking statistics. So 10% of the coronary artery disease, I think most patients, and actually most people know that it's bad for your heart to be unfit, but I think most patients I speak to are surprised that nearly 20% of breast cancer and colorectal cancer is directly caused by lack of physical fitness and lack of physical activity. And a recently published epidemiological study looking at the prevalence of cancer mapped against activity levels has demonstrated that an increased incidence in every single type of cancer that was looked at, with the one exception of malignant melanoma, which may reflect the fact that people who spend a lot of time outside exercising get more sun exposure. And so does this matter? You know, we've got an economic crisis currently and we have a health economic crisis. We need to, as we've all been talking about, get value for money with healthcare. And the estimated cost of physical inactivity to the UK economy back in 2012 was about 15 billion euros. And that means people time with, secondary illness caused by the lack of physical inactivity, its impact on mental health, which is very significant, and so lost working activity. You can see, if you have a quiet afternoon, to look at epidemiological studies of exercise and long-term health outcomes, in particular in this case all-cause mortality, there is a very consistent message in the literature. Unlike many areas of medicine, you will not find any controversy whatsoever. Being unfit means you live less long. And what's also very clear in the vast majority of studies is that there is a threshold of around about somewhere between 4 and 6 METs, which is about 14 mils per kilo of peak exercise capacity. And what you find is what's really important is moving patients from the very unfit, even if they only move a little bit along, you have the greatest impact on their secondary health outcomes by moving the least fit to a little bit fitter. Equally, you can reassure yourself at this end of the spectrum that you don't need to go mad because the health benefits plateau off at about 10 METs. And in fact, there is some evidence that extreme levels of activity may have some poor impacts on the heart. So again, in the literature, there's this concept of the 15% reduction in mortality per MET increase in your oxygen consumption. So at peak exercise, when you're exercising as hard as you can, if you could increase your oxygen consumption by the amount you're consuming as we sit here in this room, overall, there would be a 15% reduction in your risk of mortality. I don't think there's very many conditions that we could say our interventions could have that impact. And if I can't persuade you to do it for yourself, you should perhaps think about your children. So there's some shocking statistics internationally about levels of inactivity amongst children. So in the UK, 40% of 5 to 15-year-olds do not meet the World Health Organization levels of activity, which is 60 minutes a day. Physical activity is falling year on year, and obesity levels in school are rising, and more than 80% of the world's population is insufficiently inactive. So we are really storing up a absolutely huge magnitude of chronic health problems if we don't intervene to change this behavior. Because it's very clear that exercise behavior is established by teenagedom. So if you don't exercise as a child, you're much less likely to exercise as an adult. If your parents are inactive, you're twice as likely to be inactive as an adult. So there you are, there's some guilt. And then finally, there's lots of good data. If you really want your child to get into Harvard or Oxford or Cambridge, whichever one is your poison, that actually their academic performance is better if they exercise. So there have been meta-analyses, that's a reference to a meta-analysis of more than, I think it's about 70 studies looking at exercise interventions, and they improve attention for children in school, they improve executive function, which for my children is important because they're completely chaotic, and that means organising yourself, so I'm hopeful there, and they improve your academic performance. So standardised SAT scores increase if you have an exercise intervention. So why is this relevant to perioperative care? Well, I always think about this as a perioperative care pathway. We start at the beginning with some sort of form of risk evaluation and then some shared decision-making underpinning the decision to potentially proceed to surgery. And then we think about optimising chronic health conditions, but hugely importantly, at the same time, we need to optimise health behaviour. Because health behaviour determines functional capacity, and functional capacity determines not only all those other health outcomes, but also your surgical outcomes, as it turns out. Why do we measure fitness, or why do I think fitness is particularly useful, or as a measure of functional capacity? People sort of use these terms interspersedly, and I think they sort of think they know what they mean, but when I say to people exactly what is the definition of functional capacity, everyone slightly looks at their shoes. One of the problems is it's defined differently depending on sort of which literature you look at. So if you look at the cardiology literature or the physiological literature, people think of fitness and functional capacity as determined by your aerobic exercise capacity. If you go to the occupational literature, it is your ability to perform activities of daily living, and as you get fitter, sports activities. And the reason that I think it's really helpful to measure preoperatively is that your functional capacity reflects all of your health behaviours, such as your diet and exercise, whether you're obese or not, but also, importantly, the combined effect of all your comorbidities, and indeed psychological factors. Because if you have low mood, you may not be going to engage in going out of the house and exercising. If you're extremely overweight, you're much less likely to exercise. And hugely importantly, one of the problems we have in perioperative medicine generally is lots of individual organ tests which tell us about individual complication risks. The obsession, for example, with determining the cardiac risk of non-cardiac surgery, when the last time I looked in my surgical intensive care unit, what actually patients are spending longer in hospital from and getting harmed by in the majority of cases, as we saw in the last one of the abstracts, is often sepsis, pulmonary complications. Those are much more frequent, but yet we spend lots of time predicting cardiac complications. And the useful thing about fitness is whether you have heart failure or COPD, the severity of that disease will be impacted upon its functional impact, i.e. if you have heart failure but are still cycling a bicycle 10 miles a day, I'm probably not terribly concerned about your perioperative risk, and vice versa. Something else I think is really important to think about when we think of exercise capacity and functional capacity is the overlap between a number of different syndromes that we talk about. So there's first of all physical activity and exercise and the difference between those. So physical activity is just movement as in moving about. Exercise is actually a reasonably new thing in evolutionary terms. If you go to the hunter-gatherers in Kenya and talk to them about exercise, they would say to you, why would you ever run if you don't have to? Because that's a concept that is not part of their culture. We have, in evolutionary times, only used physical activity to get something, be it chasing a piece, something you want to eat, or growing something. Whereas because of our reduction in physical activity, we are now doing planned activity, which is exercise, which is a reasonably eccentric thing because it's quite unpleasant. And you need to remember that because that's why patients sometimes don't want to do it. But it overlaps with the frailty syndrome. Everyone's very interested, again, in measuring a single score in perioperative medicine. I think this is something we should really move away from. There is not going to be one test, one score, one magic bullet, which will tell you everything you need to know about a patient's outcome. And frailty seems to be another one of the latest things about that. But if you look at the definition of frailty, whether you choose to use the frailty phenotype model or the frailty index, you will see it's about comorbidities and functional impact of those comorbidities. Down here, it's symptoms from comorbidities and functional deficits. So functional impairment is a hugely important element of frailty. Just having that's actually what differentiates it from a comorbid patient. It's whether they have functional impairments. So frailty and physical fitness overlap hugely. And if you want to look at the impact of both on surgical outcome, there will be overlapping impact. And Ramani published a very nice study where she looked at the impact of a frailty score on top of ASA and the POSSUM score, which is another preoperative risk predictor. And although it did predict outcome, it didn't add anything on top of those other scores. So do be careful that we appreciate what we actually mean when we talk about frailty. We are talking about functional impairment. And then another very useful concept is sarcopenia. But again, if you look at the recent definitions of sarcopenia, it's not just about muscle mass and loss of muscle mass. You have to have, in the definition, an impairment of function. So functional impairment is really important in all of those syndromes which all overlap. And we've done some work recently looking at what is the relationship between VO2 peak and functional and physical fitness or functional capacity and sarcopenia and myosteatosis. And that's about not just muscle mass, that's about muscle quality. So how much fat is in the muscle, which makes the muscle work less well. And not surprisingly, your exercise capacity is linearly associated with your muscle mass, which doesn't come as a great surprise. But interestingly, the fitness rather than the muscle mass was more predictive of outcome than just the sarcopenia, which tells you, again, that it's function, not just the size of something that's important. And what about physical fitness and perioperative risk? Well, why do we want to measure fitness objectively? There's a few ways you can measure it, and we can start off on the left over here with your sort of subjective clinical assessment. We like to think we're good at that, but I think we're less good than we like to believe we are. If you look at the MET study, which we'll review in a moment, one of the clear outcomes from that was that the clinical evaluation of functional capacity was not predictive of anything, either complications, and it did not relate well to any of the objective measures of functional capacity. So I think we should think about that when we think we're very good at distinguishing between low and high physical fitness preoperatively. Then you can use questionnaires, things such as the DARSI, which was developed as a physical activity score for heart failure. It has a reasonably low maximum score when you translate it into VO2 peak, but it can be used. It does relate to physical fitness, and it does help perhaps rule patients out, a low-risk group of patients, rather than being terribly specific for high risk. And then you've got the possibility of exercise testing, either with cardiopulmonary exercise testing, which is the gold standard for measuring physical fitness, but also some other simpler tests for patients that can't do that, or in environments where it can't be done, such as the get up and go, sit to stand, shuttle walk test. If you look at these three patients, it's not very easy to tell from the outside who's the fittest. This gentleman looks a bit sarcopenic. You might be worried he's cachectic, but actually he's called Ed Whiteley, and at 86 he holds the world record for the marathon, having done it in 2 hours and 54 minutes. So it just goes to show you can't always tell from the outside. That's embarrassing. I'd never been able to do it that fast. So there's this data looking at functional capacity and outcome after surgery. This is one of the early cohort studies from the UK, which is really where the interest came from after Paul Older's data, which was looking at anaerobic threshold, which is a measure of fitness, and VVCO2, which is a measure of cardiopulmonary reserve and the efficiency of gas exchange, and demonstrating that mortality clearly separated between those groups that were fit or unfit when measured objectively. And subsequent to these studies, there were a lot of single-centre studies, and then more recently some retrospective multi-centre studies demonstrating that physical fitness measured either as the anaerobic threshold, which is sort of sustainable exercise, or as VO2 peak, which is maximal exercise, was reasonably predictive of outcome with an area under the curve of above 0.7, which is acceptable, certainly not perfect. And then more recently, we had the MET study. One of the interesting things about it, some people tell me that, was the end of exercise testing, and other people tell me that this actually confirmed that exercise testing was the most useful tool for predicting post-operative outcome of the ones that were assessed. So this was a prospective study from the UK, Australasia, and Canada, looking at how preoperative exercise testing, the DARSI questionnaire, and clinical acumen predicted post-operative risk. It was meant to be a high-risk population group. Unfortunately, it wasn't. As you can see, the mortality rate was 0.4%. So, and even at a year, the mortality rate was only 2.7%. So it didn't turn out to be a high-risk group. And I think really how you interpret this paper to some extent depends on which you think is the most important of the outcomes here. So the primary outcome chosen in this study, which was a North American study where there does appear to be a greater focus on cardiac outcomes, was death or myocardial infarction within 30 days. The secondary outcome, which I think many of us, certainly in the UK, may be a bit more focused on, was moderate to severe complications and death, which, as you can see, were significantly more frequent. One of the problems with composite outcomes, as you can see here, is that if one is much more frequent than the other, really that outcome isn't telling us about death, because there wasn't much death, it's telling us about myocardial infarction. And what do we find from that study? Well, we found clinical acumen didn't predict any of the outcomes, neither was it well associated with the other measures. The DASI predicted the cardiac outcomes. I can't really explain why that would be, and not the moderate to severe complications, which seemed unusual, but that was what we found. And VO2 peak was the only thing that predicted post-operative severe complications and death. And the cardiac marker, BNP, predicted myocardial injury and mortality at 1 year. The predictive precision of all of the tests in this study was not great, and the error under the ROC curves for all of these was only between 0.6 and 0.7. And one other element of the study, though, that I think is often overlooked is that actually in 28 patients, which is the same number of patients who had the primary outcome in this study, on the basis of morbidity found during exercise testing, they were removed from the study and the clinicians were unblinded. And of those 27 patients, 4 of them underwent cardiac catheterization, and I think it was 3 had their procedure changed or did not proceed to surgery. And so that's a really important element of someone who, as a clinician that has a CPET service and uses it extensively in perioperative medicine, it's one of the important uses of CPET. It's not just about risk stratifying based on a single number. It is actually useful to diagnose unpreviously diagnosed morbidity, or in fact poorly controlled morbidity. So inducing fast AF is a reasonably common event, and usually the patients who go into fast AF when you test them will go into fast AF perioperatively if you don't improve their rate control. More recently, just at the end of last year, Sham, who was talking to us earlier from the Marsden, along with Ramani's PQIP study, looking at, this is a perioperative quality improvement study, so this is a prospective multi-centre cohort from across the UK, looking at nearly 3,000 patients, and again, both VO2 peak and VCO2 and the anaerobic threshold were associated with major complications and post-operative 30-day mortality. So to my mind, that is a useful tool that will help you to put patients into risk cohorts along with other factors. And I think really where we need to go with this functional capacity data is to start using it in combination with other factors to get more precise post-operative risk prediction. Clearly, it's not just patient factors that determine post-operative mortality and morbidity. There is an interaction, first of all, with which surgical procedure you're undergoing, and there may be other factors to do with the patient that are not impacted by fitness that are important. So we need more sophisticated multivariable modelling, and we actually need to use more of the data that we collect during the CPET test in terms of cardiopulmonary reserve, rather than thinking of this threshold effect where we have one number which we think moves the patient from being fit to unfit for a surgical procedure, which I don't think is a very logical approach. So if poor fitness predicts poor outcome after surgery, is this modifiable? So can we intervene upon patients to improve their fitness and thereby improve their surgical outcome? And given that we've shown that poor fitness predicts long-term health outcomes, is there any evidence to suggest that by modifying a patient's behaviour in the preoperative period, this can lead to long-term changes in health behaviour? Because really that's what we want to achieve, because we know that health status at any point in life is only about 20%, I'm afraid, down to what we as the healthcare world are doing, and about 45% down to health behaviour. So this was some work that I've carried out at Southampton with the Fit for Surgery group, with Sandy, Jack and Mike, over the last 10 years, where we have used an interval exercise training program, which is based on the patient's objectively measured fitness to improve fitness and outcome after surgery. Why did we choose an interval training program? Well, on the basis of a review of the literature at the time, the interval exercise training in the long term has the same effect as continuous exercise training on fitness, but it happens more quickly, and we clearly have a time-critical situation with cancer patients. So that was the reason for the interval training. The same for the high intensity and moderate intensity, because again, there was evidence that it was safe in other patient cohorts, including cardiac cohorts, and again, the impact on fitness was faster. So those were the reasons why we chose that sort of program. Why did we supervise? Well, that's on the basis that adherence is very poor to non-supervised exercise training programs. And we asked the patients to come 3 times a week to hospital at this point to do this exercise training program. It started off with 30 minutes and moved after the first week to 40 minutes 3 times a week, and they do a 5-minute warm up, a 5-minute warm down at the end, and you can see here what we do is 3 minutes on, 2 minutes off, 3 minutes on, 2 minutes off. And the low intensity is 80% of anaerobic threshold, and the high intensity is halfway between anaerobic threshold and VO2 peak. And we found that we had adherence of over 90% in a variety of cohorts, including colorectal cancer, lung cancer cohorts, and esophageal cancer patients all the way through neoadjuvant chemoradiotherapy. So that was a 15-week exercise training program. So patients did adhere and were willing to do this program. This is just to give you a sample of the result. This is a randomized controlled trial in colorectal cancer patients who had neoadjuvant chemoradiotherapy before undergoing surgery. And what you can see here on the left, so we've got pre-neoadjuvant and then baseline, so that's after neoadjuvant. So what you find is, not surprisingly, that chemoradiotherapy is not good for your fitness. People tend to reduce their activity during chemoradiotherapy because they don't feel well. And not surprisingly also, it reduces at the same time your quality of life. And then half the patients were exercised in red, and the other had 9 weeks to recover from the chemoradiotherapy. And as you can see, their fitness doesn't actually recover. It ends up where it was at the beginning. And we're waiting 9 weeks when the patient could be doing something more useful. And when they exercised, their objectively measured fitness increased by 3 mils per kilo with the anaerobic threshold, and a similar amount with VO2 peak, which is both clinically and statistically significant. And at the same time, their quality of life outcomes also improved. So early evidence of feasibility and also efficacy in terms of improving physical fitness and improving an important outcome for patients. But no, this trial was underpowered to look at clinical outcomes more generally. So subsequent to that, some of you who were here on Monday would have heard about the WestFit study that Sandy presented some early data from. But this was a randomized controlled trial to look at the impact of this exercise intervention with a psychological intervention, either combined or on its own. And we performed this exercise training. It was exactly the same protocol, and we programmed the bicycles from within hospital, which were in community gyms, and the patient was supervised by a trainer, a normal personal trainer that you meet in the gym, that we had upskilled and done some additional training so that they were competent and happy to look after patients. So still supervised, but in the community near to patient homes. And this was on the basis of PPI from the patients, who told us they wanted to feel safe. They wanted to be supervised, but they didn't want to have to come to hospital 3 times a week, and they'd like it to be somewhere near their home, and they also wanted to do it in groups. And I think a really key take-home message from this is that if you are to start with a prehabilitation exercise program, you need to start with asking the patients what they want to do and where they want to do it. And in terms of appetite for this, because of COVID, we had to halt that trial and move to a virtual trial, which was for all cancer patients because of the impact of inactivity and lockdown on all cancer patients. But we recruited 1,600 patients in a year to that study. And that was a self-referral study, so patients were referring themselves. So the idea that patients don't want to do exercise, which is what people often tell me, I think is simply not correct, particularly if you've spoken to them about why it's important. We heard John Moore's talk on Monday, for those of you who were here, and he works with this group in Manchester where they implemented a prehab program based on this exercise program. Again, supervised, again in the community. We're not measuring objectively VO2 peak, but we're using the same principles of interval training and either bicycles the majority of the time unless the patient wanted to do something different. You've heard the clinical outcomes, which were impressive. WestFit led to a reduction in hospital stay of 2 days, with improved quality of life. And in Manchester, they saw exactly the same: 2 days off length of stay, 1 day off critical care length of stay, reduced hospital readmissions, and importantly, which is most exciting, I think, from that data, is sustained exercise behaviour at a year and reduced frailty scores at a year. And the economic evaluation, I just wanted to put this up because I think this is very useful for anybody who's trying to get a business case together currently. Taking a value-based healthcare approach, the Fit for Surgery program provides better patient outcomes and efficient uses of resources. So this was by the South, Central and West Commissioning Unit, nothing to do with the Manchester group. Bed days released per prehab patient. So for each 1,000 patients they treated, they released 179 beds for more patients to undergo surgery. covers the costs involved in setting up and delivering prehab for cancer for a year, and this is sustainable on a recurrent basis. And finally, the evaluation evidence can be utilised by commissioners making decisions about recurrent funding for prehab for cancer or for other programmes. And another key element from that programme is that they particularly singled out the frail patients over the age of 70, where the impact of the exercise programme was greatest. Another really important element of exercise preoperatively is the impact of exercise on cancer outcomes. Now, this is an area where I suspect there'll be a huge amount of growth in literature in the next 4 to 5 years, and I would very much keep my eye on this as a perioperative physician. We all like to think that the impact of exercise is by increasing cardiorespiratory fitness, which increases reserve at the time of surgery. But that doesn't explain the direct impact on cancer outcomes that exercise increasingly appears to have. And that's also why I think it's really important when you look at exercise interventions preoperatively for cancer patients very specifically, to look at what the exercise intervention was. If you prescribe a drug, you wouldn't forget to tell somebody what the dose is. But the huge number of exercise studies where the intervention is very poorly described, such that you would not be able to replicate it, is concerning, and it's a cause of concern for me that we might throw prehabilitation out because people are doing ineffective interventions which are not the interventions which are in the literature. And there is an element of obviously having a negotiation with the patient to find a form of exercise that is acceptable to them. But that should be within the boundaries of understanding the biological effects of that exercise, and that the effect of high intensity exercise training for good biological reason may not be the same, in fact is definitely not the same as increasing your physical activity. So just giving somebody a Fitbit and telling them to do 10,000 steps is A, unlikely to change their exercise capacity in the preoperative period, B, may not have some of the biological effects we're about to allude to, and so C, may not have the impact that you desire. I don't know, and I don't think we know, that this is the best exercise program, this interval training that we have used. The reason we have stuck with that is that it was based on the evidence at the beginning, and it has evidence of efficacy in this patient population. And now, with the WestFit trial, evidence of effectiveness. But I would be very uncomfortable about completely moving to resistance exercise because, for example, if you look at the literature, in abdominal surgery, the literature would suggest there is evidence of not being effective in the time frame that you have. It may be important for other things like maintaining muscle mass. It may be important for long-term health. But if you want to give an intervention in the preoperative period where you have a short period of time that's going to have impact, you need to be mindful of the type of exercise. And you should describe it properly using the FIT principles, which are what was the frequency, what was the intensity, what was the time, what was the type, what was the duration, did you progress the exercise? If you keep the patient doing the same thing for weeks on end, just like if you lift the same weight in the gym, you're not going to improve your fitness. I mean, it seems funny now, but when we first did interventions in Southampton, the ethics committee were quite concerned that we may actually cause the tumour to grow by increasing the blood supply to the tumour. There had been a theory previously that actually exercise may not be a good thing before cancer surgery. So as part of the ethics agreement, we did some additional scanning using MRI to not increase radiological exposure to see if there was any effect of exercise on the tumour and the response to the neoadjuvant chemoradiotherapy. And very interestingly, what we actually found was that those patients who responded to the exercise training by increasing their fitness, because not all patients are responders, and that's another question for another day, had the greatest regression in their tumour. So there seems to be a direct effect on the efficacy of the chemotherapy and the chemoradiotherapy if you exercised during your treatment. I haven't got time, and it's probably not the day to go through the detail of the cellular biology. What I would say is that the hypotheses about how exercise exerts its effect, its anti-tumour effect, first of all, there is strong evidence across tumour types that exercise reduces tumour growth. The mechanism by which this happens is not entirely clear, but reducing inflammatory mediators may be important. Reducing ROS may be important as well. Acutely, exercise is pro-inflammatory, but in the long term, it's anti-inflammatory and it dampens down inflammation. And we know that inflammation is an important predictor of metastatic spread after cancer surgery and of spread generally. And we know that patients who change their behaviour, their exercise behaviour after their cancer diagnosis, can change their cancer outcomes. So a lot of work. This is a really good review. I would direct you to it if you're interested in this area, in cell metabolism a couple of years ago, and there's been more papers since, but really along the same structure, demonstrating how exercise has an effect at all stages of the cancer pathway. So preventing the tumour growing in the first instance and enhancing the effect of cancer treatments. And so when we ask our patients to exercise preoperatively, we are hoping not only that they may improve their outcome from that operation, but they may reduce their risk of cancer recurrence in the future. I think we are at the tipping point that suggests that prehab works, and so we need to think about how we can actually get around to doing it. We need to think about this issue, which is the issue of needs-based care. We do not have sufficient resource to have supervised training for every single patient, and many patients don't necessarily need that degree of support. So we need to screen patients and identify those at greatest need. Screening, I think, needs to be right at the beginning of the pathway, probably at the point of referral from the general practitioner, not the day before surgery, when you have no time to do anything. And if someone screens at risk, you need to then act. This is the pathway from Southampton. We've implemented early digital screening, either at the point of GP referral, for joints at the point of seeing the surgeon, at the point of endoscopy in some patients. And on the basis of this digital health screen, we do our first triage into low, intermediate and high risk. And we determine not only what their preoperative pathway is, but also what their perioperative care pathway may be on the basis of this. And we can start that process then right at the beginning of the journey. What does the screen contain? The screen is not a pre-assessment. It is not an exhaustive list of comorbidities about which most of things we do nothing. I've never quite understood. We seem to have gotten into this thing with pre-assessment when we write down hundreds of chronic health conditions, most of which are not modifiable, which don't really affect what we do, and then we feel better about it, but we've left it right to the last minute when we can't change the things that are modifiable. So what we put in this screen are the things that we think are important. So the DARSI screen is the first functional capacity screen, a nutrition risk score for malnutrition, something about psychological well-being, the Edmonton frailty score because the patient can do it themselves. We ask about alcohol consumption, chronic pain to identify those who are high opiate users so we can intervene, smoking, and risk of sleep apnea. This is what it looks like when it comes out in the electronic notes. Everything is red, amber, green for risk, and then underneath that title it has which questions they flagged on. We then have developed a clinician dashboard that allows the perioperative medicine team to follow patients up, because one of the problems is we look after patients in multiple pathways, and then it's very easy to lose people who might be off having a nutritional intervention or having further investigations. And if you click on any of these, you've got surgical details, function, and these interact with the rest of the record to be able to identify where the patient is, and then we identify their pre-assessment pathway based on their risk and what prehabilitation pathway has been involved beforehand. So a green patient on that screen will go straight to telephone assessment, and then they become part of the waiting well. So this is a list of patients that can be brought in at short notice because they're low risk if there has been a last minute cancellation. Has it got any validity, this tool? Well, this is not published data, but we looked at an arthroplasty population locally. Reassuringly, the patients we said were low risk spent over 3.5 days in hospital. If they were outsourced to a high volume elective hub for low risk patients, that was just under 3 days, whereas the intermediate risk patients about 5 to 6, and the high risk patients 10 days. The reassuring thing is that you identify that patient group that are going to use a lot of hospital resource. Did the patients do it when we did this and changed it to an electronic tool? Well, actually, I was really impressed because we did this in the arthroplasty waiting list, which were a hard nut to crack because they were elderly, they were comorbid, they'd been on the waiting list for a year, and anybody that was at all healthy had already been done in an outsourcing centre. But 70% of them completed that risk score when they were told that it was important for their perioperative care. And 76% of that 70% did it on their own. You can see here about 25% needed some help. We have these things called digital health assistants to help them. And for patients who don't want to ever interact with the digital phone and think it's evil, then what we do with them is we have them on our electronic patient record, but we complete the questionnaire by telephone. It takes about 15 minutes and the patients think is acceptable. It takes the average patient 18 minutes to fill out the questionnaire. What are our universal prehab interventions? We have a surgery school that was developed by Imogen Fletcher-Jones here, who's our lead nurse. You can see the outcomes there. The majority of patients are happy to attend. About half of them say they're going to change their behaviour. About 60% of them say they had changed their behaviour, but that was asking questionnaires, not measuring. And the patients that came, I mean, that was not a random sample, but we've looked at the length of stay and complication rates in those who attend and don't attend, and it was greater in the non-attenders. Interestingly, when we looked at the patients who were most likely to come, cancer patients were more likely than non-cancer patients. Vascular patients seemed to be a hard nut to crack. During the pandemic, we moved the surgery school online, and what we found, to our surprise, was that the attendance increased by 10% and the intent to change behaviour also increased. If it's so good for you, why don't we do it? This is really important, I think, as a group in perioperative medicine. If we're going to start asking patients to actively exercise, we need to understand the science of behaviour change, and there is an entire literature about it, and it's about supporting patients to change behaviour because it's not easy. Those are probably lists of reasons not to exercise that you all recognise, and lack of self-efficacy is really important because it tends to be higher in patients from deprived backgrounds, and that is basically the ability to manage your life on the one hand, but equally your health conditions on the other hand. These are patients that tend not to turn up to appointments, tend not to take their medication. We've co-developed with industry an app which supports patients in the preoperative period for the low-risk patients. And importantly, we have an exercising element, a psychological element, a nutritional advice element, and we screen within the app using the same tools I mentioned earlier, and the patients are nudged to screen every 2 weeks. But equally, it incorporates some behavioural change important bits. So checklists, SMART goals are really important. So when the patient's inside the app, they're asked to create an exercising goal. We then ask them when you're actually going to do it and what might stop you from doing it. We also then ask them to confirm when they've done the exercise, and they get a gold star essentially. And it might sound terribly patronising, but it's been demonstrated that if you ask patients to diary their exercise, they're double as likely to do it. And if they have decided what they're going to do, and if they've thought about what might stop them from doing it before the exercise starts, you're more likely to get adherence. So where are we now in Southampton? On the basis of the trial data, we really want to implement a service now. All of our patients who are having face-to-face supervised exercise to date have been in the context of pilot projects or QI or research studies, because in the NHS as it stands currently, this is not a NHS-wide supported or funded service. We will carry on with the triage we do early. We will carry on with surgery school, and we're implementing the app for the universal patients. Those patients at intermediate or high risk come up for a prehab assessment. That involves a cardiopulmonary exercise test, a dietitian assessment, or a psychological assessment for someone who has high psychological needs. And then their prehab is targeted. It's a personalised prehab plan based on what their needs are. And this will be delivered in the community. Southampton is here. We have a large tertiary referral area, but we have contacts in gyms in all of the major areas that we serve. And those gyms will be delivering the exercise program using the exercise referral scheme. It's really important to engage the community that already exists in your area to deliver this. We're not going to reinvent an entirely new workforce when one already exists, but you need to do the assessment, which is the complex bit probably, and prescribe the exercise in hospital. So we give the prescription, we've done the assessment, we've convinced ourselves it's safe for patients by doing the cardiopulmonary exercise test in the high-risk patient group, and then we allow the patient to transition to the community. And as we did in the Westfit study, if we have concerns, we do the first 2 or 3 training episodes in hospital, and if there have been no adverse events, then we transition to the community once you have the confidence of both the patient and your confidence. And then there is an escalation plan for all of those individuals in the community, so that if the patient turns up with a swollen leg, for example, they know who to call and when they can and cannot exercise them. So across our integrated care system in Wessex, there's support for system-wide delivery for a consistent, the same universal health screening across Wessex using the My Medical Record screening tool I mentioned, and then a hub at our hospital for the assessment and personalised prehab prescription, and then community delivered for the vast majority of patients. So I'm going to stop there. I'm just going to leave you with these thoughts. Imagine a pill that reduces all-cause mortality. that reduces the risk of cancer, heart disease, stroke, depression, diabetes, frailty and falls, and dementia, with minimal adverse effects, that improves outcome in cancer, surgery, heart disease, diabetes, depression, that improve cognitive outcomes in children, and makes you feel better, function better, and sleep better. Surely you would prescribe it. Surely you would want it. Thank you very much.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.